This conference will now be recorded.
So welcome everybody to the December 21st high-risk recurrent and advanced prostate cancer video chat virtual group. I was just saying before I turned on the recording, sign up to the blog so that you get a notice of the recording and also look at the language of cancer post that I just put on there a few minutes ago. I think what we'll do is just go down the list quickly and see how many people will need time tonight, at least now, and then we'll add the other people after we've spoken to Bryce and Brad. I'm going to do the roll call and the ask all in one, and then if I miss anybody at the end, please tell me. So Jake, anything you want to raise tonight?
No, thank you.
Okay, Peter, anything you'd like to raise tonight?
Only discussion about the new pills.
Okay, well that's good because we will talk about it, and maybe also Dr. Mark and Herb and Len can chip in whatever 2 cents they have. By the way, I just sent you guys the note that I got from Myovant. I don't know if there's anything new. There is a call tomorrow morning, Wednesday morning, so we'll mention that. Oh, wait a minute. No, maybe it was this morning, but there was a call. Sorry, I'm getting confused. Jimmy Greenfield, anything for you tonight?
If there's time, sure.
Okay. Frank F, anything for you?
Yes.
Okay. Dennis C, anything for you?
Nothing tonight, Rick. Thank you.
Okay. Russell, anything you'd like to raise?
Nothing at the moment, thank you.
Okay. Jeff, anything you'd like to raise? Say that again. Sorry, missed you, Jeff. Okay, there's something up with your mic, and so we're not hearing you. You're sort of crackly and muffled.
Which Jeff?
Jeff M.
I have nothing to this week.
Okay. Now, Jerry P, anything for you?
Just a quick update.
Okay, you got it. Carl, anything for you?
Yes, please.
Okay. Paul, anything you'd like to talk about tonight?
Nothing for me tonight.
Okay. Vern, anything you'd like to raise tonight?
Nothing new, thank you.
Robert, anything you'd like to talk about? Well, you'll have to give us an update. You haven't been with us for ages, so we'll need an update from you, Robert.
He's on mute.
Are you there, Robert? Unmute.
I was on mute. I'm unmuted, and yes, thank you. I'll give an update.
Okay, for sure. Les, anything you'd like to talk about?
Tonight, thanks, Rick.
Okay, I was hoping Santa Claus was going to come and give us a little Christmas story, but what, I don't know. Ben,
At least a ho ho ho.
At least a ho ho ho. Thank you, Jake.
I thought he was going to say pro prostate.
pro prostate. Very good, John. Ben, anything you'd like to talk about?
No, mum's the word.
Okay, Ken, anything for you?
Nope, I'm good.
Good. Joel, anything you'd like to raise?
No, not tonight, thanks.
Alan, anything for you, sir? We missed you last week. We couldn't, you came late.
Yes, I could use a few minutes.
Okay. Peter M, anything for you?
No, thanks, Rick. I'm good.
Okay, Sylvester.
No, thank you.
Okay, Herb, anything you'd like to raise?
Shook his head, no.
No. Okay. By the way, I think everybody knows, but Herb has joined us on the moderating team, which we are very, very happy about, and we welcome him gladly. Mark Finn, I know you've got a little update for us. Is
Okay.
that true?
I'd be glad, but put me at the bottom of the list. I'll see the other people who have other stuff to do.
Well, listen, people always say that, but then they do have important stuff. So you're on the list.
Yes, sir.
Okay, John I, anything for you?
No, sir.
Okay. Was that a yes, sir, or a no, sir?
That was a no, sir.
Oh, that was a no, sir. Okay.
No.
Okay. Mr. Jackson, how noisy is it on the Eastern Front?
The Eastern Front is quiet.
It's quiet. Okay, well, I'm glad to see you in the group. Len, anything you'd like to raise?
Niente, nothing.
Okay, and your video's working fine now.
Yeah. I don't know what that was about.
Okay. David M., anything for you?
No, sir. Thank you, Rick. I'm good.
Okay, good. And Tracy, I still don't see you on my screen, but I know you're with us.
Maybe just a quick update.
Okay. And is there anybody else who's come in that I have missed other than Brad and Bryce? Okay, well, we're good. So let me just do a quick count. 1, 2, 6, 7, 8, 9, 10, 11. So, all right, that gives me a pretty good feel. I think we probably should spend about 20 to 25 minutes or so with Bryce and Brad, and then we'll move down the list. So I think I hope most of you read the reminder. I'm sorry if it came out a little late this week. That said, if you did, you'll know what I'm going to say, and if you didn't read the reminder, you're going to find out. Bryce Olson is a prostate cancer social media star. If you follow social media, you will have seen his name. And Ken Anderson in particular. And Bryce, I don't know whether you know, but we have a separate group for this that focuses just on men under 60. And it's moderated by Ken. It's a really interesting group, and it's in response to the fact that most prostate groups are full of old farts, which is true. Sorry.
Hey, it's all good. All good.
And so we do have that special group, but this is the big group that you're in. But there's going to be at least, I can see at least 2, if not 3, and there may be more joining us who belong to your category. And Bryce has been through most available treatments. And together with his buddy Brad Power, who is also on this call, and a third gent, Paul Kane, I think it is, they are hosting what I would call a virtual tumor board on Wednesday morning around Bryce's case. But this tumor board is going to include not just doctors, it's going to include scientists, and it's going to include patients, some expert, some not, some who think they're expert, some who are expert but wouldn't say so. And so I invited Bryce to tell us a little bit about his case. I don't know that we can rival the tumor board that's going to happen, but we sure do have a lot of information and knowledge here. And I also asked Brad to talk to us a little bit about what he's doing, and maybe an opportunity for some of our guys, and we've got a couple who are in a position somewhat similar to Ken to possibly do the same thing going forward. So, Bryce, what we usually do, and we're in the process of formalizing this, is we ask new men to take the floor, to give us a little bit of their history, how old they are, where they've been treated, where they are in their path. I think you've probably done this 101 times before. You can do it in your sleep. So I'm going to hand the microphone over to you, and we'll get Brad involved in a few.
Okay, great. By the way, my 12-year-old daughter is upstairs. She thinks I'm an old fart as well.
Oh, okay.
So, yeah. So it's good to know we're all brothers in this fight here. It's an honor, first of all, to be in front of all of you today. Thanks for this opportunity, and I kind of look forward to having a relationship with you all going forward here too. So a little bit about me. I got diagnosed with really aggressive metastatic bone disease back in 2014, early 2014, and no history really in my family. You know, I was very active, ran every day, surfed. I'm at the Oregon coast right now, though it's really windy and stormy right now, so I won't be getting in the water at all. But a very active guy, never got sick, and you know, I'm also on a high deductible health plan at the company I work with, so I kind of felt that I was gaming the system by not going in and getting any physicals, because then I don't spend any money, right? So I remember I was surfing out here in the summer in 2013, and all of a sudden I noticed that I was having to pee more often. Like the frequency and the urgency of the urination was starting to get out of control. And I don't like to pee in my wetsuit, because it you know, it feels really warm for a second and then it gets really cold, and it's really gross. So I just didn't like to do that, but I found myself like having no choice. If I wanted to get a 2-hour surf session, I was going to pee like 4 or 5 different times. And eventually I went in. Long story short, I had you know, all 12 cores positive on the biopsy, Gleason 9 when they resected the prostate in March of 2014. 85% of my prostate was consumed with very high-grade Gleason 9 cancer. It had rolled into the seminal vesicles. It was a little bit into my bladder, and I had a little bit of micrometastatic disease in a lymph node. We thought we kind of rolled the dice and said, let's see if we can get it all. And even though I had one of my margins wasn't clean, and so I did everything that I could. I was doing ketogenic diet and just all kinds of other crazy stuff to try to shore up my my fighting healthy cells. But 6 weeks later, I found out that I had, you know, my PSA, by the way, you know, I've got one of these aggressive variant prostate cancers, most likely, right? So my PSA, even with everything I described, was only at about a 6.5, and post surgery, it only dropped to 3.4. And the screwed up thing was like, why is it 3.4? It should be 0. We could see nothing on conventional imaging when I initially got biopsied and when I initially got diagnosed. So it made no sense that my PSA had only dropped in half. Well, we ran in and did another CT scan, bone scan, and just in a period of 10 weeks, now I had like 2 or 3 lesions the size of quarters on my pelvic bone. So it was like explosively growing really fast. I then you know, it was 2014, the chartered study had been out. So I went into, you know, docetaxel and Eligard right away. Like, you know, 6 rounds of docetaxel. I'm sure some of you guys have been through that. That's a lot of fun, right? So flash forward to early 2015, I started feeling a little bit of pain in the hip. I did a CT-guided bone biopsy to see what was going on. I was also starting to get the religion for genomics around that time. So we saw some rapidly dividing cells. I sequenced, like sequencing is a big deal for me, right? I'm like the sequence me guy. So like I sequenced my cancer, found out that I had hyperactivity in a cell signaling pathway called the PI3K, the PI3 kinase. I had PTEN loss as well, which is a tumor suppressor gene on that freeway. So the cancer was using that freeway to just, you know, think of Smokey and the Bandit, right? Remember how Bandit and Cletus are hauling ass delivering beer from from Texas to Georgia because Coors Light is illegal. And then the tumor suppressor gene was like Buford T. Justice in Junior. You know, they're not paying attention as bandits hauling ass, right? So that's what was going on in my case. I had hyperactivity in this cell signaling pathway called the PI3 kinase. So I found a phase 1 clinical trial drug, and I started going to Cedars-Sinai for 2 years, and then I shut it down like nothing. Like it just had 0 PSAs. Like it was great. That drug failed, but it didn't fail me ultimately because I had genomic data. It was the only way I was able to get into the trial. And when the drug failed, because 90% of phase 1 drugs fail, when that thing failed, all the drug supply from all the different sites went to me. So I had single patient IND status from the FDA, and I was able to stay on it for another year. I'm not going to go through the entire history with you, but I've been on 8 lines of therapy, excluding surgery, and 4 different stereotactic high beam radiation treatments. So I'm really big about when I get a new lesion, I biopsy it and then I kill it with stereotactic high beam radiation. But I've been through all the alphabet soup. I've been on Provenge. I've been on abi with prednisone. I've been on a number of trial drugs, including right now this thing called atezo-cabo, which is atezolizumab. It's an anti-PD-L1. Cabozantinib is a targeted drug that helps get the T cells into the tumor. It's also a VEGF inhibitor, so it prevents vasculature. And like I mentioned, I've been really big about sequencing. Every time I get a new lesion, I sequence it. Sequencing has been really, really great for me, and I've helped a lot of other people get access to that, and so they know how to open up new doors and stuff. But the reason why Brad and I are here is because I'm even hitting a wall right now. Like, I like to say that if you're a precision medicine 1.0 patient where you've never had your cancer molecularly profiled and then you go do it, you're going to find something on the other end that you can take as a drug. I'd say probably 80% of the time. But if you're like me, who's been on this rodeo 3 different times or so, DNA alterations alone don't tell the whole story. Like I need something better than that. And so I was talking to Brad before an article in Wired magazine that was about my story hit about a month ago. And I was just like, Brad, what can we do? What can we do that would be kind of transformative? Because I need to go. I love my oncologist. She's amazing. I go all the way to San Diego for care because she's the bomb. Like she is amazing. But even her alone is, and even all the connections that she has with Prostate Cancer Foundation and all the other doctors that she does research with, I still wanted to access a bigger brain trust, if you will. So Brad said, well, why don't we do a hackathon? Why don't we reach out to groups that could bring bioinformaticists, scientists, researchers, medical professionals together, where I take all this amazing data that I have about me, right? Like multiple genomic cancer tests, imaging files, clinical data, all that, put it out in the wild, let all these bioinformaticists bang against it and compare it with data sets that they have. And then they're going to come in with inferences on things that I should go do, right? And this would include places like Tempus, Foundation Medicine, Epic Sciences, Decipher Biosciences, like just Illumina, like blah, 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 blah. And then you get different individual oncologists who also can look at my data and say, I think I know what would be really good for you, right? So the concept is this. We put my data out, let all these scientists and researchers bang on it and come up with different ideas. Then those ideas are going to roll into a virtual molecular tumor board on a national-wide level, where we're permissioning in my favorite oncologist in the prostate cancer world. We're going to look at these different ideas that come in along with their own ideas. And then we're going to work with a company called Xcures, who's got, really cool software that can kind of promote up what we should do, what would be my next 9th course of therapy, if you will. What Rick was talking about this Wednesday, that's not actually going to be the tumor board. We're going to kick off the process. So all these researchers are coming in Wednesday, and we're going to tell them what we're up to. I'm going to make my data available. And then a group called Research to the People is the organization that's going to go find all these bioinformaticists. And they're all going to come back to me and say, oh, I love the fact that you have RNA sequencing data from Tempus. Super cool. But what you don't have is whole genome sequencing or single cell RNA data or blah, 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 blah. And we can generate that for you. So then that'll be a new data set that'll come up. And, you know, it's just gonna, I think when this thing is all done, I'm gonna be the most molecularly profiled patient on the planet, probably. You know, it's kind of a new paradigm. It's like, you guys know how high school athletes who are 5-star athletes get all the colleges coming to them, right? Like they don't have to work that hard. They just get the colleges coming to them. Well, I want to position myself to be like a 5-star cancer athlete, if you will, a 5-star prostate cancer patient who's got all this amazing data. And now all of a sudden researchers across the United States are interested because they can advance their science and they can also help me. So that's what Brad and I are up to. And the goal of this is to, once we figure out something transformational for me, how do we scale this? So a bunch of you guys, if you're hitting a wall, again, this is for guys who are hitting a wall. They've done all the standard of care. They've tried all kinds of exploratory stuff, and they're like scratching their heads with the doctor on what to do next, you know? This is for those kind of people. And so we're trying to bend the healthcare system to the patient instead of the other way around. And that's really it. And, you know, maybe if Brad has any additional comments, we can open it up for him, and we can open it up for questions too.
Brad, please go ahead, because there's a couple of well, let me just do one thing. A couple of clarifications with you, Bryce, just for us. Was your 9 a 5 + 4 or 4 + 5?
That's a great question. I don't know. I think it was 5 + 4.
Okay.
But I don't know.
And what was the drug that they used to heat up the tumor with the atezolizumab?
Oh yeah. So yeah, let me elaborate a little bit on that. So as you guys know, right, like most prostate cancer is kind of cold tumor. It doesn't light up, like the immune system doesn't see it. So when you do profiling, like these immunological biomarkers, right, like tumor mutational burden, microsatellite instability, PD-L1 expression, like unfortunately, most of us, we have cold tumors. It doesn't light up. The immune system doesn't see it. So even if you take a checkpoint inhibitor and release the brake on the immune system's kind of like, okay, what do you want me to do? I don't see shit, right? And that's kind of what happens to most of us. So in the case of like me, who doesn't have a immunogenic cancer, you try to add something else to the table that would kind of make it light up a little bit, make it a little bit more immunogenic. And honestly, that's one of the things I'm really looking forward to on this collaborative cancer research case, is to like, let's look inside my tumor microenvironment and see what we could either turn on or off with a drug that could wake up my immune system to see the cancer better. Because this drug that I'm on, it's called cabozantinib. It's a VEGF inhibitor. So it inhibits vasculature, right? So vasculature is like angiogenesis. It's cancer's ability to lay down all this pipeline and to get nutrients and to continue to grow. If you inhibit that, you're also kind of inhibiting the cancer's ability to hide from the immune system, you a little bit, right? So the theory is, if I can do that, then maybe I have a better chance of the immune system seeing the tumor, but it's debatable. I mean, I'll tell you right now that in the last 20 months, I've been on this clinical trial. The good is that I've had no new metastatic lesions in the last 20 months. The bad is that current disease started to slip away from me. And during COVID, I skipped a couple of cycles because I was afraid to fly. And so what happened to me was the soft tissue component grew out of my T5 vertebrae, wrapped itself around my spinal cord, and I almost had a cord compression. I had to do like emergency spinal surgery and do a corpectomy to get the bad cancer and the whole vertebrae out. And then we did a fusion of 3 vertebrae below and 3 vertebrae above. So I'm still kind of reeling from that surgery right now. You know?
I mean, we go back a long time with cabozantinib, not with an anti-PD-1, PD-L1, but I mean, I can think of guys 4 or 5 years ago that were doing trials with cabozantinib. Len, I think Dom did cabozantinib. I'm not mistaken.
I don't recall that, Rick, but I thought that I am recalling a failure of cabozantinib in prostate cancer. It didn't work. I mean, maybe in your case it's working, Bryce, but do you know about that trial for cabozantinib that they discontinued in prostate cancer?
I think the endpoints were debatable. But I can tell you that I'm pretty sure it's not the atezolizumab that's having the impact on me, like, because that's just an anti-PD-L1, and my cancer doesn't really care about checkpoint inhibition. I can tell you that the Cabo is toxic as hell. Like I was on 40 milligrams, and life sucked on that. I think about 6 months into it, I just told them I got to go down to 20 or I'm going to drop out. Yeah, I don't know about you guys, but I'm really big on quality of life over quantity. I gotta have great quality. Like bad quality is just 2 stars. I don't want that.
Do they still believe that it's the PI3K that's driving your cancer?
Yeah, so if you look at all the genomic cancer testing that comes from Tempus or Foundation Medicine, yeah, but I've already drugged it. You know, I drugged that pathway and I had success for 2 years, but then I built up some resistance to it. I chased another PI3K inhibitor from Lilly, and I think my ship has sailed on PI3K inhibition. Yeah.
So I want to jump in here. I'm Herb Geller. So yeah, I agree that, you know, we've been very precision medicine oriented, and you are, and you're a great story. But I'm a scientist, and so the way my life works in my lab is the world goes from DNA to RNA to protein. And when you're talking about PI3K, AKT, PTEN signaling, this all can happen without any change in RNA level and without any change in mutations. And so is there any thought by anybody? I mean, so in my lab, we look at signaling pathways. There are assays that can tell you if AKT is hyperactive. And has anybody ever, and I don't know, and this is a question which perhaps I should know, has anybody thought about saying, well, let's, instead of looking at genomics and RNA, maybe we should look at the signaling that's hyperactive in your tumor using assays for signaling?
Yeah, I would love to. And if that's something that your lab's able to, I'll tell you what's going on right now. So Tempus doesn't report out, for the most part, gene expression data, but they looked at it for me, and because I asked them for it. And so they compared my gene expression in their database against everybody else in the database. And the interesting thing is that I'm really high in AR. You know, even though I'm probably ARV7 positive right now because I failed abiraterone after 9 months, and in the gene expression, they feel like they can see that I'm ARV7 positive, they think. But my ARV7 gene expression is still really, really high. So that makes me kind of curious about a protein degrader because, right?
Well,
because
there is
it's
this
just,
drug in phase 1 trial.
yeah, Arvinus, right?
Right. Well, I mean, basically, it's a ubiquitin light. It's basically the ubiquitinates the receptor for degradation.
Yeah, exactly. And then interestingly enough, there was oh my God, I'm forgetting it right now. I can pull it up, but there's something else that I'm really high. My expression for PI3K is just like middle of the road, nothing big. But I'm really high on CDK9 or something like that. I have to go look. It's like it's common in blood cancers. So, you know, there's something there maybe. And, you know, if we could mass spec proteins, that would be cool. I don't know if anybody can like do that at the level that I would need, but
They might. I mean, I think you need to mass spec proteins. I would also look for phosphorylated proteins.
Yeah.
Because those are the ones that are signaling.
Let me I want to bring in Brad, and I want to throw it out to everybody. And Herb, I hope you will have the opportunity to join Wednesday. Um,
Yeah, Herb, send me your email address. I'd love to connect up with you.
Hers easy. herb@ancan.org.
Right.
Okay. Okay.
herb@ancan.org.
Okay.
Right. Hello, good to meet you.
Nice to meet you all. This has been a great, I don't know, kind of a joy with Bryce. He's such a catalyst. I'll just say that we had this brainchild of an idea like 4 weeks ago. And in that time, almost everybody we've reached out to has said, yeah, I'm in. What can I do to help? And so we've got sort of a dream team of research oncologists for metastatic prostate cancer. We've got all the diagnostic companies saying we'll run tests to add the data to Bryce. Research to the People is working with Stanford Medicine. They're on board to host. Cancer Commons is going to, and XCures are going to host the virtual molecular tumor board. Pretty much you name it. Anybody we've approached, they've said, I'm in, how can I help? And we're moving at a very rapid speed. We were saying, for example, we're going to have our launch, and we were saying, should we have it this week or should we wait till after the holidays? And we said, well, Bryce can't wait, so we're going to do it this week. So Wednesday morning, 9:00 a.m. Pacific, we're going to have our launch. And the other thing Bryce didn't say, in addition to the insights he's already garnered from Tempus, we also, in the outreach we were doing, we were introduced to Sumit at MD Anderson, and he had a whole novel therapy. And Bryce, I can't follow all the stuff you're talking about, but maybe you can share, because everybody on this call seems to be quite knowledgeable about these treatment options. You might describe what Sumit came up with. But my point is, we have 2 lines of possible therapy options for Bryce that did not exist prior to 2 weeks ago, and that he might not have gotten from his oncologist and the very excellent team that he's working with. Anyway, Bryce, you might say something about that other line.
Yeah. Well, yeah. So like Brad was saying, this came back with really interesting gene expression data, and also some trials that could connect into that. Like I mentioned, the Arvinus thing that Herb, that you were familiar with, and then some other things that are connected to gene expression. They were also looking at just my PI3K, mTOR, AKT, and combining it with other hormonal drugs is something to consider as well. What was cool about Sumit is he's like, I can look at you right now and pretty much tell that you're aggressive variant prostate cancer, considering everything that you've been through. That scared the shit out of me, honestly, because like that's quote unquote neuroendocrine prostate cancer, and I do not want that. And I'm kind of hoping that I'm actually not quite there. But he felt pretty strongly about that cabozantinib and atezolizumab is probably not going to get it done. And honestly, when I chart, I've got this chart where I look at my PSA on this axis and then timeline here. And then I look at all the interventions that I've had, and the last couple of years look really bad, and the last 20 months, even though I've had no new disease, my PSA is just up and down. The only way I can bring it down is through either surgery or radiation. So I know I've got to pivot onto something. And so Sumit was saying, just real quick, Sumit was talking about an EZH2 inhibitor along with an anti-CTLA4. So like IPI along with EZH2 inhibitor. And just because he feels like other things are probably not going to really work. And so that was just interesting, it was an interesting insight.
Let me jump in, because we at some point within the next 5 to 10 minutes, we've got to move on, because we've got 10 or 11 people that need time tonight.
Yeah, all good.
Yeah. Whole area that we haven't explored with you that we would love to explore. You have not mentioned once any of the BITE trials. And the
what?
The BITE trials, the bispecific T-cell engagers. Thank you. I always get stuck on the E. Anyway.
Yeah, the bispecific stuff.
the bispecific stuff with T cells, and they're doing bispecific stuff with T cells, with chemotherapy, with different things. But we're you know, the T cells in particular are very interesting, and you probably saw the recent webcast by Alicia Morgans with Oliver Sartor and Tran from Australia reporting on AMG 160.
No, I have not. I haven't seen that.
What I want to do right now, I think we blogged it. I think I blogged it. I'm not sure. What I want to do right now is we've got a couple of guys whose disease, you know, the disease doesn't become neuroendocrine disease. What it does is it morphs into a profile that looks more and more like neuroendocrine disease. And we've known this. I remember when Eric Small explained this to us in the UCSF Research Day, probably 7 years ago. But I really would like a couple of the guys who are in similar situations just to speak up a little bit before we move on. I mean, I'm thinking of Ken Anderson, first of all, who's in your age, who was diagnosed under 60, but he just turned 60, but we don't count that. And we've got a couple of other people who are exhausting regular treatments. But Ken, what? I mean, this must be very interesting to you to listen to.
Well, first I'd like to say happy holidays. And yeah, I was interested because I've actually seen your story on, I'm from the Northwest. I live in Arizona, but at the moment up in Washington State towards Tacoma. The whole, you know, your whole like concept of looking for the brain trust to help in your path is a great thing. I think it's got great potential if you can get some of the, you know, like Charles Drake and some of the other ones here in Portland, maybe Todd Beers, to come on and try to help find, you know, a good path. I mean, 7 years is a pretty good stretch, and I know the whole idea of trying to pick the next is always in the back of one's mind, and it is in mine. You know, right now I'm finishing up, going to be doing 12 rounds of docetaxel as a re-challenge since docetaxel works. But I've pretty much gone through most of the treatments. I'm looking at some of the bite trials, but I'll follow along kind of what you're doing because it makes a lot of bloody sense. So try to get as much information as you can and try to share that with people. And I know that's what the large institutions do. You know, they collect data from everyone. And I do go, I see Paul Korn at MD Anderson, and I think they're a great place for cancer care. But I'll follow along, and thanks for coming on and sharing.
Well, thank you. Thank you very much.
Who anybody else would like to just talk to Bryce before we get into the the round robin and the people who need time today?
You know, it's Larry Fish. I just wanted to say that when you talk about that brain trust, it just seems like all those people are so busy. You're going to put them all together and get them all working as a team.
Larry, we can hardly hear you. Can you get the microphone closer to you, or?
Yeah, I'll try. Is that better?
Yeah.
A little bit, yeah.
Right, I'll speak up into this. I don't know what the problem is, but it seems you're talking about a brain trust, and I'm picturing how all these hardworking top scientists, professionals, are going to all come together on a single project and spend their time on it. I'm thinking that in general, it's more of a like Deep Blue or the Go program, Master Ghost, where you need like an artificial intelligence program to collect this data from those guys, have them put their input, and kind of make the best analysis, you know, coming up with the best solutions. I don't know. I know they're working on that, but I don't know where it is or how it exists. How do you get to that streamline? How do you get into that pathway?
Yeah. No, so I work at Intel Corporation. I work on health and life sciences sector, and AI is a huge portion of what I do. Most of the companies that we are working with, including the Tempuses of the world and everybody else, like they've got some really amazing analytical tools that, you know, are based on AI. And some of the stuff that's going to emerge out of this are going to be bioinformaticists using a lot of analytical tools and, you know, some of the AI stuff that they have. I don't think we're going to have like a Watson thing where everybody's just going to dump everything into that. I wouldn't trust it if we did, you know, honestly. But we are absolutely using cutting edge technology on this, and it's going to actually open up opportunities for tech companies, I think, to get involved as well once we find out if there's a gap, you know. Like, for example, I'll just give you one example. So if I release my data and I want Ellie Van Allen at the Broad Institute, Dana-Farber, to take his prostate cancer, you know, metastatic prostate cancer project data and combine it with mine, he's not going to ship his over to us. I can get mine available, but you know, if he wants to look at my data and then in conjunction with Johan de Bono's data and other people's data, you're going to need the right kind of technology that can send analytics to where the data is and not the other way around, right? And you know, things like that, right?
You know, Ellie is a great friend of ours, and he's on our advisory board. We lost a really dear researcher, Bill Burhans, last year, who worked very closely with de Bono. We know directly or indirectly a lot of these names. So look, we would love to keep talking to you.
Likewise.
And I hope you'll keep coming back and you'll participate in some of the discussions we have on a regular basis. You're very welcome. I hope you'll join Ken Anderson's under 60s group. It's a slightly different flavor to this. And we just want to keep talking to you and support you on your journey.
Thank you.
And maybe we've even got along the way a couple of decent ideas that you can feed in.
For sure. For sure.
We've got some terrific people in this group. So bear with us, stay with us, Brad. If you have to leave,
hold on, Rick.
Yeah,
I'd just like to.
Yes.
Hold on, Rick. I'd just like to say, do take a look at Ben Tran's video from ESMO this year if you haven't seen the bite information. It's pretty interesting.
I'm gonna look at it. Yeah.
Yeah.
I've talked to my doctor about. I'm trying to remember what it was. It was a PSMA with something, CD something, I think. But there's a number of these bi-specific projects
T-cell
under.
engagers.
Yeah, and I'm very interested in them. It's definitely something we're looking at. But I want to use the power of the people, the research to the people, and get a lot of this data and have people come back and say, you know what, based on your unique molecular, your molecular makeup, we can tell that this thing would be really good for you. Like I want that kind of level of insight, and I'm hoping that one of them is one of those bispecifics, because I think they have a lot of
fingers crossed that you get the information you're looking for.
Thanks,
Right.
Ken.
One other question. Did you do PSMA scans?
I did. So here's funny.
Did they light up?
Yeah, here's a funny story. So now that I've got all this gear in my back, including pedicle screws and cement and artifacts that conventional imaging they can't see anything. They can't tell cancer between that and all the other junk that's in my back right now. But a PSMA PET scan can. That thing lights up like nothing else, And so I was down in UCLA, and here's the story. It was wonderful and horrifying at the same time. So I only have 2 spots that lit up. One in my iliac bone that I've had since 2014 that's starting to grow. And then they told me I had something in my T5, and I was like, that's impossible. I just resected the entire T5 vertebrae and have a mechanical vertebral part in there. I can't have any cancer in my T5. That makes no sense. But turns out I did, because they left a little bit behind to help shore up the fusion, and that was where the cancer was, and they didn't even see it. So, they got most of it. I debulked like 90% of it back there, but they still had some left behind, and PSMA PET was wonderful for me.
Guys, we must move on, otherwise we're going to have an angry peanut gallery.
All right, I'll shut up.
I want you to keep coming back and share your knowledge with us. It will be really helpful, and hopefully we'll be able to contribute to you. And I just want to let everybody know, I think most of you do, there's a lot going on in the chat window. The chat window is the little bubble at the top. And if you open it up, you'll see some of the conversation going back and forth between the participants, and some really good links that Brad has posted in there, and others. So let's start with Peter's question, because I think it's an important topic that's on everybody's mind right now. And you know, we won't spend too long on it, but we definitely need to highlight it this week. So Peter, please start.
Came up at the last meeting, but it was kind of shut down because the thought was that it hadn't been approved yet. But I guess this new LHRH drug is approved now. And I'm just curious, I haven't done all the reading yet, how effective it's going to be. I know there's some issues around the heart, but there's issues around the heart with other drugs as well. But we just want to see what the collective mindset is, and whether it's something worth pursuing, what the benefits are. Because I'm wrestling a little bit, because I just recently had to switch to Eligard from Lupron for whatever reason. Lupron's kind of disappeared off the planet, and I feel a difference, which annoys me. So anyway, I just want to bring that up. What this new drug is about and what it can do for us.
Yeah, well, we will definitely talk about it, but the switch from Lupron to Eligard has been positive or negative for you, Peter?
Negative.
Okay. I mean, as we all know, you know, some guys do better on some of these LHRHs than others. And, you know, one guy could do badly on Eligard and benefit from Lupron, and in Peter's case, the other way around. So I want to raise two quick points about relugolix, and then move it over to Len and to Herb. We spoke to Myovant probably 6 months ago, and Len astutely pointed out to them a couple of flaws in their trial. One of which was that they were comparing their agonist in the trial to antagonists. They were comparing their antagonist, the oral drug, to agonists in the trial, which was a real problem. For us, we thought a real problem, because it was like somewhat comparing apples to oranges when you talk about the side effects, especially up front. And there was one other thing, Len, you'll probably remember what it was. So that's a good segue to get into you. What was the other thing? Remind me.
The other thing was that they were defining castrate levels of testosterone at 50 nanograms, which may have been the case years ago when Lupron was first approved. But of course, now all the docs consider castrate level of testosterone to be less than 20.
Right. So, Len, you've posted on this a couple of times.
Right. So, yeah, the two important things coming out of that trial were that the obvious thing, which is true of Firmagon, the other antagonist, is that the T levels are brought down much more dramatically and quickly than with an agonist. The second thing was that recovery to within 90 days, the recovery to normal levels of testosterone were something like 50% with the new drug, relugolix, but only 3% with Lupron. So in other words, this would be important to guys who are considering intermittent androgen therapy. So if they stop taking relugolix, their testosterone levels will, the majority of them will be back to normal in just 3 months, whereas with Lupron, only 3% of them will have T levels back to normal within 3 months.
One of the things to take into account there is also there have been some reports that people go a month on Lupron versus 28 days, which is the indication. And some people actually break through and they start to see a T rise before they get their next dose. With Firmagon and this, if you miss a day, well, not Firmagon, but with an oral medicine on a daily basis, if you miss a day or two, you may end up with a significant rise in testosterone. So it's going to be less tolerant of compliance issues.
Herb, would you like to add anything?
I think the only thing that I would add is that at least in their New England Journal paper, which was for the trial, they did say that there were fewer cardiovascular events. So that was something that I thought was also positive about this medicine versus the others.
Yeah, but
which is also true of Firmagon. Firmagon has been shown to be less cardiotoxic than Lupron.
Yeah, but as you pointed out, even though there are less events, they actually highlighted the electrocardio problem.
Yeah, the FDA did, yeah.
Oh, it was the FDA did. Okay.
Yeah.
What did they compare to when they said less cardiac events? Was it another agonist or was it?
No, they were, not the agonist. They weren't doing antagonists.
And were the levels of testosterone comparable? Because if you're not bringing down the levels as low with the antagonist, then you might see you might see fewer side effects. The question is whether it's the drug itself, if it happens in both classes, or is it the degree of testosterone suppression?
Right. Any questions amongst the group for the guys? Yes, Jake.
I just have a comment. Chances are there's going to be an insurance issue with this new drug. Firmagon, Lupron are treated as chemo drugs by Medicare, and they pay 80%, and secondary insurance often picks up the difference. Now, I don't know if the new drug, relugolix, will it be treated like abiraterone or Xtandi, not covered by insurance, but by Medicare, or will it be treated like a chemotherapy drug like Lupron and Firmagon? Just a thought.
Well, my guess is it'll be for those on Medicare, it's going to be a Part D drug as opposed to a Part B or C B drug.
That's what I'm afraid of too. Yeah.
And there are issues there too, as some of you found out when you list your Lupron, which is currently a Part B drug, on your as a Part D drug, you get some very strange results that you don't want. I know one of the guys did do that and then came to me and asked me about that. And in fact, right now, Lupron is considered to be like a chemotherapy, even though it's an injection. I'm fairly sure that this pill will not make it onto the Part B formulary.
It'll be interesting to see how the urology community deals with this, because the injections have been their bread and butter up till now. If you can just sit there and take this stuff at home without going to the urologist or the hospital, I mean, that's a boon in my thinking.
I agree with that for sure.
Yeah. All right, we're going to keep moving. Again, we could be talking about this one for quite a while, and I have a feeling this will not be the first time we discuss this. But there is some real logistical advantage to this type of drug, as I think everybody on this call has done a significant amount of hormone therapy and therefore can appreciate the difference. So let's go to Jerry Pelfrey. We haven't heard from you in a while, so it's good to know you got something to tell us. I hope it's good.
Oh, it is, Rick. I went up and saw Dr. Singh this past week, and we all that. Not going to have any more imaging until June of next year, but that's because my PSA has stayed below 0.1, as Mayo does. You know, they don't check below that, but I on my own have checked, and I'm at 0.02. So he had nothing to say about the labs. They're all within what he considers the right specs. And he said, I'll see you in June. So one thing I will say about this, since that was Phoenix, and Arizona is not doing very well with COVID, but thank goodness my wife and I made it through both Phoenix and Tucson without too much trouble. But to Phoenix and Dr. Singh, we're looking at doing a lot of it virtually. And I think Dennis does it already virtually with Dr. Singh, although I'm not sure. But that's it. I mean, it's the best thing in the world. It's very quick, right to the point. Everything's fine. And
Yeah, my last visit with Dr. Singh was telemed.
okay.
After,
You're not doing any Zoom with him, huh?
I couldn't hear you, Jerry.
Yes, his last visit was a telemed visit, Jerry.
Yeah, I heard that. But Dr. Singh wants me to do a Zoom next time, not telemedicine. Well, it'll be telemedicine.
I mean,
Same thing. That's what we use. We use Zoom to do the telemed. Yeah.
Yeah. I don't. Let's not get into a discussion on the platform, but the concept is that, Jerry. So you're just going to hang in with the Lupron and Abby. Is it Abby? Or, I can't remember.
Abby. Lupron, Abby, and prednisone. That's it.
And for Bryce's benefit, we ought to tell Bryce that you were diagnosed 2 years ago with a PSA of 3,000, right?
Yep, 3,194.
Yeah.
Yeah, and I got it down to below 0.1 by November.
Show off.
February to November. But
well, you know what it is. Those prostate cancer cells don't like living in San Carlos, Mexico. That's what it is. So they've all emigrated north of the border, Jerry.
Well, good. I'll just stay down here then. But
did you wave when you went? Did you wave when you went past two back?
I did.
Good.
But it was. But listen.
Yeah.
Driving this week during the holiday season, we knew better, but this time I had to do it. Waiting at the border was 3.5 hours.
Yeah.
We've never done that before.
Yeah.
And then coming back, it's really interesting and funny in a way. But all the Mexican Americans that have their families down here, they load up their trucks and then they load up a trailer and put it behind their truck. So they're going down the road, the highway with a truck and pulling a trailer that's just absolutely packed.
Listen, Jerry, I drive behind them I drive behind them regularly on 19. We need to move on, but we're delighted with your news. So let's talk to Robert, and just give us a little bit of background. I don't even have you in my records, so I don't know what happened here, but please fill us out a little bit.
Okay. I was diagnosed in March of this year. And in April, I was put on hormone therapy. I'm currently taking abiraterone, prednisone, and I have a heart condition as well. So instead of Lupron, I'm going in once a month for a Firmagon shot. I also take 225 milligrams of Effexor in the slow release or the extended release to help with the hot flashes, which it works really well. So I've had some.
How much are you taking, Robert?
225 milligrams in a
right. Yeah,
extended release.
Yeah, yeah. 3 capsules. Yeah.
Well, actually, it's only one. It's a 24-hour.
Oh, right. Okay.
Yeah. And I have my prostate out on September 1st, Dr. Carroll. And I see Dr. Small and Dr. Fang. I had the oligo-Metastatic prostate cancer, and so I only had 2 sites, and I had trouble with my left hip. So Dr. Fang radiated that 5 times, and it seems to have fixed that. I still have one on the right side that we haven't decided on, because once I had my prostate out, we're just recovering from that. And I've had UTI infection since then. So I'm going on another set of meds to try to get rid of this infection going on for me. And I see people obviously at UCSF. I'm 75 years old. And that's pretty much me.
Okay. And what questions, if any, do you have for this group?
Well, a question I have in general is, now that I've had my prostate out, and it was a good pathology report. It hadn't broken through the capsule, and everything was good. And that was one of the reasons I wanted to have my prostate out instead of radiated, so that I could get some diagnostic information. But I still have a question about the one metastatic site lesion that I have. Is this hormone therapy treating that as well, or do I need to get in and get that radiated with some treatments? That's probably where I am with the. Oh, and then the other thing I had a question about, because I am doing the Firmagon, is this cardioelectrical. I don't know what that is exactly, or that they're having, like with relugolix.
Right. So let's take the easy stuff first. What was your post-Gleason score?
It was an 8.
4 plus 4. Okay. And where's this metastatic site? Is it lymphatic, or is it in the bone?
It's in the bone. It's in the right hip.
Right hip. Okay.
Yeah.
So, Len or Herb or anybody, would you like to address this issue, this question, as to whether it should be radiated, or whether we should just, if it were you, would you just let it respond to the LHRH and the abiraterone? Herb.
I think, if we look at the Oriole trial, which is the trial that defines oligometastatic disease, really it would say, and the answer, by the way, to your questions is yes and yes. The abiraterone is working on your metastases.
Okay.
But if I think according to the Oriole trial, they would go out and get that second, they would use radiation to get that second lesion.
Okay, great. Thank you.
Len?
Yeah, I agree with that. You could do either, because in my case, I had, depending on how you interpret the scan, 3 to 5 bone mets. And I
Yes.
went for a consultation with Zalewski at MSK to see if he thought spot radiation would be appropriate. And he said, no, why don't you just go on hormone therapy or continue it, because I was on intermittent therapy at the time. I was on drug holiday, but I had previously had hormone therapy. So he recommended I go back on, and he said then we can see, maybe we can make some of them disappear and we'll radiate what's left. So what's happened to me is just on the hormone therapy alone, the PSA went down to 0.02, and it was 2.4. So just the hormone therapy alone pretty much took care of the metastases.
Okay.
I mean, that's the limit of detectable, the 0.02.
Yeah, my PSA went down from 32 to undetectable on the hormone therapy.
Okay.
Yeah, you can do either.
Mm-hmm.
Len, would you just like to explain the cardio question to Robert?
Oh, well, what they see in patients on Lupron are arrhythmias. That's what they mean by the electrical cardiac problems. And sometimes they need to put you on a pacemaker.
I have one. I'm on a
pacemaker.
Yeah.
So you said you're on Firmagon, right?
I switched to Firmagon because I heard that the Lupron was more heart toxic.
Yeah. Okay, you did the right thing.
Okay. Yeah. Thank you.
Sure.
Anyone else like to dialogue with Robert? Okay.
Thank you.
Pleasure. I've got 3 people to check in with that I think I either forgot to ask or have arrived since we asked. One is Larry Fish.
Nothing for me, Rick. Sorry.
Okay. One is Jim Jeffries. Jim, anything you'd like to raise tonight? You're muted right now.
Back on Lupron as of today, but nothing major to report.
Okay. And Dr. Mark, did I ask you if you had anything to raise today?
No, I'm just sitting here. I was all excited about exercising on my Peloton, which was scheduled to be delivered. It wasn't, and they said it will be delivered sometime between Wednesday and February 15th.
Oh, man. Okay. All right. So we're gonna keep moving along here. And Alan Moskowitz, because I sort of shorted you last week, you came in a little late and we didn't get to talk to you at all. So
Okay, thank you, Rick. I'll be brief. Just a quick background. I had a prostatectomy about just about 7 years ago. 4+3 Gleason, and eventually I had to have 6 months of Lupron along with radiation, and all this time, eventually the PSA started up again. And as I mentioned to folks here several months back, my PSA sort of leveled off a bit at the beginning of this year. It stayed at about 2.3 for 2 consecutive 3-month apart readings. And I thought that was very encouraging. And people said at the time, yeah, there were some folks here with experience that said, yeah, it could level off a bit, it could go up again. And it did go up again. In my reading in September, it took a big jump up of about 0.5. And so then I was up to about 2.9 something. And I got a reading last week, again 3 months apart, and it only went up about 0.11 to a little over 3. And so my question is, I mean, I do have a long doubling time. It's at least 15 months. Depending how you calculate it, it can be as long as 18 months, which of course is good. And my medical oncologists, 2 of them said, that's great, just let's stay the course, no treatment needed. But the question is, you know, it seems so odd that the PSA doesn't follow sort of a smooth curve upward. And I wanted to know if any folks had any further experience with that or had some explanations about that. You know, it's I keep thinking, well, maybe it's related to what I'm eating or the amount of exercise I'm doing or I'm not doing. And I'll take any thoughts on that, but I don't want to take up too much time. So I'll, you know, just throw it out there.
And if I'm not mistaken, one of your oncologists for Mr. Nathanson's benefit is Dr. O, right?
That's correct. Yep, I had a teleconference with him in September, as well as my other doctor at Sloan Kettering.
Right, and you're in Monroe Township, so not too far from Ben.
Okay, right.
Who would like to talk about this PSA issue of does it have a mind of its own, shall we call it? Anybody want to comment on that? Len.
I'll take a stab. I think you can chalk it up to some phenomenon that's called cancer dormancy, Alan. So for reasons not particularly well understood, a cancer lesion due to some influences in the tumor microenvironment just remains dormant. And it doesn't progress and it doesn't disappear, but it just kind of goes to sleep for a while. And hopefully, as it appears to be in your case, it'll be a long sleep.
Well, it seems to rear its head every so often and takes a little jump up. Yep. Okay, so that's fine. I mean, you know, do you think it relates to anything diet-wise or lifestyle-wise? I mean, it's a guess, of course, but your guess is maybe better than mine.
Well, it's always good to maintain a healthy lifestyle, exercise, a heart-friendly diet. They always say is a prostate cancer-friendly diet. So, right. Mediterranean diet.
Right. Yeah, it's a strange thing. Both these oncologists tell me there's no need to start treatment. They say you have a long doubling time, just wait and see, maybe get another scan, some either Axamin or PSMA perhaps, when I get closer to PSA 4 or even a little beyond. They tell me not to worry. My local urologist, he's of course frantic. He's telling me I should be having treatment. And I keep telling him, don't worry about it. I said, I'm in good hands. But still, at the back of my mind, it's always nagging at me whether I'm making a big mistake. Hopefully not, but time will tell.
Well, I think my if it were me, the one thing I would be doing is I would have a PSA number in mind that I had agreed on with my GU med oncs, of which I was going to start treatment.
Yeah.
I mean the because you're getting up there now with 3. You haven't resumed your or even started any LHRH. And I think there should be a number at which, whether you're doubling at 3 months or at 2 years, that you say, okay, it's time. Anybody else face this situation? Has anybody else faced this same situation with their doctors? Guess not.
Guess not. Yeah, Rick. People, these both of the medical oncologists have expressed that thought, and they said, yeah, it could be around PSA 4, it could be 5. Some of them even have patients that the PSA goes up a lot higher than that, 10 or more. Again, it depends in part on the doubling time. I don't think I'd be comfortable waiting that long, but in my mind, it's somewhere probably around 4. You know, it could even be sooner. It depends on whether or not I get a scan sometime in maybe the first half of next year. Probably I will do that. You'll recall my scan at Sloan in March at PSA 2.3 didn't show anything.
Right.
And that was sort of maybe disappointing or maybe not, depending how you look at it. So probably one more scan and then that's it, then probably treatment.
Well, I agree with Rick as far as having some sort of target. If your oncologist or your urologist think the target is something over 10, I'd get a new urologist or oncologist.
Yeah, of course. Yeah, it'll be 4 or 5 is what sort of the first, the more sensible targets in my mind are, according to them. Very good.
But I have a question though. Haven't we learned that it's a combination of PSA and the results of a scan is to tell us what to do?
Well,
yes. The answer is yes, that we need both. But as Alan says, he's going to scan within the next 6 months again. Now, if his PSA, God forbid, he tests again in 2 months and his PSA has gone to 6, I bet that scan will get accelerated.
Right.
Yeah.
Well, I would say it's a combination of both, but the realization is that unless you're going to dig down into your pocket, you're not going to be able to have scans that often. And so therefore, you're going to have to rely a lot upon your PSA as an indicator of when you should get a scan, unless it's just a matter of you've been, many, many months without a scan. So I don't think it's a combination of both. I think you're right, but I think the PSA can often be the leading indicator of what's going on.
Right. Yeah, that's a fair point. Very good. Thank you all.
Pleasure.
You're welcome.
All right. Can we move on? I hear a resounding yes. Silence is a resounding yes. Okay, let's stay in Monroe Township. Carl, what's up this week? Tell us.
Okay, following up from my discussion last week, I had my latest maximum PET scan, and that was this past Thursday in advance of my participation in the upcoming clinical trial for PSMA scan at Stony Brook, which is in 2 days. The maximum scan was pretty encouraging. It showed that there is only one possible spot. It's not in any of the bones. The bones are showing as sclerotic, and the spot could be, and it's small, and it might be in the lung, which I've been told could be easily zapped with radiation, according to the radiologist. So pretty good news with that. I haven't yet met with my oncologist until after both scans are completed. And as I had mentioned, the purpose of the PSMA scan is to see how much more sensitive it is than the maximum scan, and that's why they wanted me to have that in advance. So I'll be on my way to Stony Brook, New York in 2 days.
Okay. Well, good news that that's the only spot that we seem to see. And as Ben Nathanson knows, because he spent 2 hours talking to Jerry Deans, we know people that have done pretty well managing spots that appear in the lungs. Of course, they're not BRCA positive, so that makes it slightly more complicated, but that is good news. Who would like to talk to Carl about this trial that he's in, or the spot in his lung, or anything else? Anybody?
I have a comment, and I'm going to ask Rick as well. Rick, you have mentioned in the past with respect to PSMA scanning that sometimes a blood test is given, I think, to determine if you do have that PSMA antigen in your blood, or maybe it's urine, I don't recall. Yet, when I was down at NIH and as well as at Sloan, they don't do such a thing. And I think I asked Carl about it, or maybe dropped him a note on it to find out at Stony Brook if that's the case. But I've not heard where one can get that, or is it only something that UC at San Francisco offers? Could you comment on that if you can?
I would rather Len or Herb do, because I too see it sometimes that they'll do the test to see if you are PSMA. What's the technical word? PSMA
Avid.
Avid. Thank you. PSMA avid or not, but they don't do it in other places. Enlighten us, gentlemen.
Herb, you want to take that one?
Oh, I think Len, I really don't have any knowledge, so I really can't say anything.
I mean, the only way that I'm thinking they would know is if you had a lesion and they took a biopsy, and then they'd be able to tell if it was PSMA avid or not. I mean, if there's another way, I'm not aware of it.
I mean, a blood test would imply that you're shedding PSMA, and I don't know that that's the case.
Well, remember, it could be 10 to 15% of prostate cancers don't have a PSMA antigen, or it's very, very low. And so, you know, no PSMA-based scan will then find it, right? Because it's not going to uptake that antigen, or that tracer, rather.
I mean, they definitely test for PSMA, because I know with the lutetium, the guys that have been in the lutetium-177 trials, PSMA, they do check if they're PSMA avid, but I don't know how they check.
With the PSMA PET scan.
And my trial is not requiring any kind of blood work.
Right. Well, again, it is a question to ask them, but they definitely do try, because the guys that have gone to, the guys that went to Houston and to UCLA, and the guys that go to Germany, that they all get tested first to make sure they're PSMA avid, but I don't know how they check.
I mean, the way, I mean, I'm looking, I just did a quick search in literature, and these are very old papers from 1990s. And they're basically saying that they use what's called an ELISA assay with antibodies against PSMA to detect if it's in serum. But from my understanding, it's not all that common, that it's not shed routinely.
I find it odd that these clinical trials take place without doing that upfront test, because it will sort of mess up the data a little bit, because you'll get all these false negatives, right?
No, Alan, so if you have PSMA, it's a protein, it's a protein that's on the surface of the cancer cell. So it's attached to the surface of the cancer cell, and that's why you can image it, because it sticks right on the surface. And so there are many proteins on your cell surface which never appear in your serum, because they just stick on the cell surface. So they have to be shed by some mechanism in order to get into a blood test. And so that's why you wouldn't necessarily see it. And really, the issue is more, where are the cancer cells that are PSMA positive?
Well, my point is, if 10% of
Yeah, no, let me cut you off, Alan, because I got you, and I agree with you. The problem, don't know how they do the test. And if somebody wants to do a little more research here and let us know next week. But yes, sometimes they're tested, and maybe Carl will come back from Stony Brook with the answer, because I'm sure that if he gets to speak to any of the PIs, they will they'll be able to address it. Jimmy Greenfield, how are you? We don't have any mystery celebrities in this crew, Jimmy. Just you. Don't say we can't hear you again. I don't think we can hear you. I wonder if it's the connector on. Jimmy, it could be that you've got to tell GoToMeeting to pick up your headphones.
He had sound earlier, Rick. When he first came on, he had sound and it was working. Okay.
Oh, okay. Well, we'll let you, Jimmy, will go ahead. I don't know what it is, but sometimes we're good with you, sometimes we're bad with you. I don't know what it is. I'm frustrated, and I know you are. Go out, maybe go out and come back in again. We'll keep moving, and we'll come back to you, Jimmy, for sure. Okay. Frank Fabish.
Yes, I have my next appointment's tomorrow, and my oncologist wants to talk about chemo with docetaxel. I have some questions going in with him because last month I was 1 month on Firmagon injections, and my numbers dropped down drastically. My PSA went from 2.82 to 0.75, and my testosterone went from 298 to 15 in 30 days. So he gave me my second injection, and I'm going back in tomorrow. They'll do the blood tests, and I'll see where it is at that time and if it's going to drop some more on both of the key markers. My point with the chemo is I feel that I should have a CT scan to determine the size of the 3 lesions on the lungs, the nodules. They saw it in September, and each one of the 3 was about 1.1 centimeters. I would like to see how much, if any, they've gone down in size, being in January, being 3 months on Firmagon, and if they've gone down significantly in size, should we still go another 2 or 3 months on the Firmagon and then talk about chemo if it hasn't gone away? So I wanted to throw that out. Am I thinking incorrectly, or is that valid?
Well, I think I would even go one step further. I mean, you've had some somatic testing done that showed no mutations, but where was that tissue taken from where they did the somatic testing, Frank?
Are you talking about the biopsy that was done?
Well, yes, I guess it was a biopsy. And it was a biopsy that you sent away for analysis. Was that taken from the lungs?
Yes, that was good. They went directly through the back into the lungs, and took 3 samples, and they came back as prostate cancer metastasis, and that's when my doctor started me on the Firmagon injection that same day when we reviewed the results.
But my notes say they sent that away for sequencing and it showed no mutations. Do you know if was that true?
I don't know.
Okay. Just verify whether they have done a genetic analysis, a somatic analysis of those lesions. So they need to be sent away. And the reason I say that, I said in the past, I know I've got it right here in my notes that they had, but you should have a report. And if you do, maybe you can send it to us. We can take a quick look at it. But people that get lung lesions, there's usually something unusual or more unusual about their disease, and a greater likelihood that there may be a precision medicine available. Or you may need a more tailored type of chemotherapy beyond docetaxel. And that's why I'm asking these questions. But let me throw it out to the guys as to, and you only have 2 lesions, correct? There was nothing else.
There were three lesions, nodules on the lungs, and I also had 1 lesion on the pancreas. But I went to a specialist oncologist for the pancreas, but they had done a CT scan on me in 2016 when my prostate cancer was detected, and the size of the lesion was the same size as it was in 16. And the doctor looked at it and they said, it hasn't grown, it hasn't shrunk, we'll just continue to watch it.
So, and you're not, he wants to follow this up with apalutamide, but right now you're not on any second-line anti-androgen, you're just on the Firmagon, correct?
Right, I'm just on that, and what he's recommending, or he did the last time and said he wanted to discuss it tomorrow, is go through 6 doses of the IV treatment, and then he will start me on apalutamide.
Right. So let's go to the guys and see what they say. Let's throw it out to the group. I have a couple of ideas, but let me throw that out to the group. Frank started his Firmagon just a couple of months ago. He's seen a significant drop. He's got 3 or 4 lesions. If it were you, what would you be what sort of discussion would you be looking to have with your med-onc when you went to see him tomorrow?
I kind of agree with, this is Jake. I kind of agree with Frank. If it was me, I would wait before jumping into chemo. You know, give the Firmagon another couple of months and see what kind of effect it has.
Anybody else?
I'm a little bit confused.
Hold on, Peter. Herb had his hand up and wanted to speak. Herb?
Peter, you go ahead.
I'm confused. I heard you say that he did get it sequenced, but we don't know. I'm not sure about that.
My notes say that he got it. Frank said he got it sequenced, but Frank is not sure right now.
Yeah, I have it in my file, but I don't know where it is. It's in front of me, but the actual report of the biopsy, but I don't remember specifically.
That would be we're not talking about a biopsy report here. We're talking about a genetic analysis of the tumor. That's different. So it's not the biopsy report. That's a hepatotic analysis. What we're talking about here is whether the tumor has been sent off for analysis to see if you have any genetic mutations. And if it hasn't, I would say, if it were me, I would want it first.
Yes.
Now, the genetic mutations, if I went through a genetic study and submitted for that, and it came back as not anything that they found, and they couldn't find anything, is that what you're talking about?
Yeah, if it showed no mutations at all, yes, that's what we're asking.
Yes, I did have the genetic study done through the James, and they sent it off to, I think, a lab in San Francisco, and it came back where I had no mutations in the genes that indicated anything that would help in my treatment.
Right, but was that
Was it a genetic or a genomic testing?
Hold on a minute, Mark. Let me finish, and then you're welcome to come in. Was that test based on blood or saliva, or was it an analysis of the tumor?
It was on blood.
Okay, so what you've got to do is you've got to find out if that test was looking at your inherited mutations, or if that test was analyzing the own mutations of your tumor. Because today, a blood test could do either. And what you need is a test. It can be done through the blood, or you can send off the tumor. What you need is a test that will reflect that analysis. Really important.
Okay.
Really important. So go ahead, Mark.
No, nothing. I just said that whether you have a genetic test, which is your inherent genes, or whether you have a genomic test, which is a test which looks specifically at your tumor, which you assume has some mutations or something that's different. I wasn't aware that you could get a genomic test from the blood. I thought the blood was mostly going to be a genetic test.
No, it was recently approved by the FDA, the liquid CDX test by Foundation Medicine, and also a test, I think, by the lab that starts with an M. I can't remember their name right now. But there's another lab, there's another genetic lab, and they both got approved recently. Go ahead, Herb.
Well, I mean, it sounds to me like you're responding to I think you said Firmagon?
Yes.
So we've lowered your testosterone. The tumor is responding. So it's a hormone sensitive, it's a hormone dependent, hormone sensitive tumor. And, you know, according to the Stampede trial and Charted, you probably could just as easily start on one of the second generation hormone drugs, such as abiraterone or enzalutamide, and see what happens. And then the other part of this is all, which, you know, again, if you have relatively few lesions, and I mentioned this thing called oligo-Metastatic disease before, they are potentially targetable to pick them off with radiation. So I think if it were me, I would go with hormone therapy and then see about radiation and then hold on, because I went through chemo, and there are guys here who went through chemo. It's no picnic. And if there's another way around it and it'll work, I think you'd be better off.
So, yeah, I mean, the studies suggest that for somebody like yourself, chemo is not the preferred course. The preferred course with few lesions like you do not have a heavy tumor burden, is to do the LHRH drug, the Firmagon, plus a second line. Your doctor wants to start you on apalutamide. The trials would suggest abiraterone as being the more effective drug to begin with. And then after that, to go to the androgen receptor blocker. So the literature and probably the standard of practice right now would be for you to get abiraterone rather than chemotherapy. But you've got to advocate, if that's what you want to do, you've got to advocate for that with your doc.
Yes, well, he wants to discuss it tomorrow, and that's what I wanted to do, was to be prepared to discuss it with him and bring this to him with what I've heard here, and I know after hearing everybody the last 2-3 weeks, it sounds to me if my body is responding to the Firmagon in the manner that it is, and we go and we continue on Firmagon for another 2 to 3 months, and we see the reduction in the nodules in the lungs there, then wouldn't it make sense to continue with it? And then, as you said, bringing in a pill form to help boost it more on the adrenal glands, and then see where we stand at that time.
Yeah, but that should be done now and not 2 months from now.
Right.
That's what it suggests.
Mm-hmm.
Okay, I mean that's what it suggests. But guys, we've got 10 minutes left. I got to keep moving, but I think we've given some ammo. And please ask him if they have done a somatic analysis of your tumor. Very, very important.
Yes, I will.
Okay. All right. Now, Herb, did you ask for time? I can't remember. I got a yes, but I can't remember.
No, but I think Jimmy is on the phone, if I'm not mistaken. Jimmy, I think he's caller 02. Is that correct, Jimmy?
I'm on the phone.
Fantastic. Okay, Jimmy, you're up.
I can't get the camera. I'm going to fix all this. I am. I thought I was past it, but I'm not. But you can hear me on the phone, right?
Hey, great. And we can just imagine those 2 guitars on your sofa next to you.
Yeah, not having the bling for you to look at is hard on me, but I'll try to get by with that. Let me be brief. You know, I talked to you and you've been very helpful, and I just feel like, you know, I'm still I'm not getting any response on second opinion calls, but I'm still trying. But I am, as I told you, leaning on putting my trust in Ken Pienta. I went through a lot last year. It didn't seem like a lot at the time, but in retrospect, it was. I did have that, aggressive clinical trial, and at a year now, with the opportunity to go off of the ADT, I'm sort of inclined, and it looks like I'm doing it. And I have mixed feelings about it. I'm definitely ambivalent, especially after what you've said and what some other people have said. But I went back and talked to him, as you know, and he feels strongly that there is no benefit to being on any longer in my case, and that for myself, the thing that I haven't really put to anybody is, what is the real difference anyway? Along with the quality of life issue, which is that, even though I've tolerated it well, as we know, it ages you. It's difficult. I kind of want to enjoy what remains of my youth, which is dwindling. But everything that I do is slower. My mind is slower. I play sports. I'm slower of foot. I'm slower reaction time, slower everything. My musicianship is the only thing that remains strong, and that I'm thankful for that. and I'm a sweetheart to my wife because I don't have any testosterone. But other than that, you just feel like, you know, the longevity game is also kind of bothering me a little bit, whereas I think that it's becoming extremely overrated. And I'm not looking forward to the grave, especially an early one. But, you know, I'll be 65 next month, and people tell me how young I am or how young I look or how young I act or something like that. And I just know that I'm not young anymore. And I'm kind of, you know, the ambivalence is strong, and I'd like to stick around. And I have not found ADT to be intolerable, really. But on the other hand, as we all know, it's a grind. And if my oncologist is telling me that it's an opportunity for me to go, it's hard for me to say no to that. And I haven't said no to it yet. And I still have time to get another 3-month Eligard shot if I decide, but I better hurry up because this is the month. So that's where I'm standing.
Well, let me throw it. And you've done about 15 months, is that right?
Yeah.
Okay. So just to remind everybody, Jimmy had he had a radical prostatectomy in June of 19, and he started LHRH in September of 19. They found a positive lymph node.
They found that in the pathology report. Yeah.
Right. And so, like some of others of you who are in a similar situation, but maybe didn't have the RP. So let me throw it out as to what other people would do.
I should add that I, as part of the aggressive trial, I had abiraterone on the front end with chemotherapy, with Taxotere in September, along with the Eligard.
Right.
And then radiation in February.
Right, but you stopped the abiraterone and you and the docetaxel, which was 4, but you stayed on the LHRH. So
yeah, as directed.
Guys, what are your thoughts for Jimmy?
Jimmy, this is Peter. As someone who's done intermittent 3 times for over 6.5 years, my feeling is, as long as your doctor's suggesting it, and if you get blood tests regularly, like every month or 2, and just really keep an eye on things, you know, keep on top of stuff, you could probably do intermittent ADT. You know, if you see things starting to double or climb, or see something, you know, starting to look a little bit odd, talk to your doc, and you can always go back on and knock it down again.
Kind of what I'm thinking. He has said that he has I asked him if there's a number that he would resume treatment, and I think he said it was 0.4. And he said that he would certainly not turn first back to LHRH, that there are other things that he would do first. He didn't say. But he also said that it might not happen for a long time for me and that the medicine is changing. And he specifically said he didn't really want to say what he would do in a couple of years because it could be very different than what he would do today.
Right. And it's my experience is it's not the absolute number, it's how fast the number rises. That's
right. Yes, doubling time. I'm aware. Yeah. Well, I've been undetectable since post-op and all through this, and I know that the Lupron may be mostly responsible for that. But you know, again, I'm just sort of taking my shot. As far as the testosterone thing goes, I feel like I just want to kind of get it over with. It may sound strange, but you know, I twist in the wind thinking about whether, you know, my PSA is going to rise and metastases will grow because my testosterone does. If I can't have any testosterone, fine. I want to just damn well find out. And that may sound odd in some way, but that's kind of how I feel.
It'll probably take 3 or 4 months for the testosterone to come back. My experience.
Oh yeah, I'm aware of that. But I also know that the longer you're on it, the harder it is for it, less it might come back. Len was saying earlier too that first 3 months that 3% get it back to. I don't know what the level was, but I know it sometimes doesn't return at all. Sometimes it returns to sometimes even measure it by castrate level. That's 50. Coming back to 50, what are you gonna celebrate and pop the champagne because it came back to 50. I don't even know why they measure that, but that's not my business.
400 3 times at 4 months.
Right. Right.
6 years.
Well, I had 700 when I started, and you know that's fine and dandy. But naturally, if I came back to 300 or 400, I would probably notice the difference. It's so weird because now I can't even remember what it's like to have testosterone, and it ruled my life most likely for the first 50 years of my adulthood.
Anybody else on thoughts of whether to continue or to get off at 15 months? Yes, David.
There's someone.
Go ahead, David.
You know, it's all about risk. And I hear you that you're more comfortable just knowing that you're there. But if you're watching it closely, like Peter says, give it a shot and see what happens. I know that a lot of the men talked about, and I haven't had a chance to do a holiday yet, but a lot of men, including Len, talk about how great it is just being able to take a holiday and having your youth back. So if it were me, I would take the risk and see how you feel. As long as you're watching it, you know you'll catch it as soon as the PSA starts to rise, if it rises. But give it a shot. Have some faith in your doc.
I appreciate it. And I don't want to take any more time, but I think I want to say one more thing. And that's that you guys have talked about, Rick, you've talked about this specifically, not referring to cure with men in our situation. That cure is a word you don't like to use. And it's at odds with a little bit with what I've seen from some other, you know, well-known oncologists in the YouTube world, and even Ken Pienta told me when I started the trial, he said that I had a somewhat slightly better than 50% chance of cure. So myself, I'm defining cure as dying of something else first. So that I am a little short on comorbidities. You know, I fear that might be a long time. So I don't know what to think about that.
Well, I'll respond on two issues. The first is, and this is totally anecdotally, that we've seen in this group the best results for people who stay on the LHRH for at least 18 months first time around. And the guys who get off earlier are the guys who seem to have the most problems. It's totally anecdotal, but I know that if it were me, I would not consider getting off at 18 months as much as I would have loved to. You know, I did 28 months, and as much as I would have loved to, I thought I was best to stay on, and I did stay on. So my view is give it 18 months. The second thing is to cure. It bothers me when we hear docs talk about cure and you got a 4 in the number. You can have a durable remission, but I don't know anybody that's really had a cure. Now, if you define cure as dying from something else, yeah, that certainly can happen. That certainly can happen. But we don't have evidence that when you got a 4 in your number, that your treatment is going to completely eradicate the prostate cancer from your body. Anybody else want to comment on that?
You know, Rick, it's Ken. I can give you my 2 cents. I mean, I understand Peter's comment, and Jimmy, I heard everything you said. I would have to agree with Rick that I'd probably bang on it a little bit longer, and I know it's not fun. I mean, I'm still on it, so it's definitely not fun. But if you want to get a durable remission with a 4 in your number, and again, I can second Rick's comment in regards to cure, and it's a big difference between cure and durable remission. But you know, getting a durable remission for someone such as you or I is something we all shoot for. So the more you bang on it and keep the cells to the least activity as possible, I think the better chance you'll have on getting some kind of long-term hold. So I wish you well and happy holidays.
Okay, I'm gonna leave this with a smile on my face and laugh because, as usual, I have fine doctors and fine gentlemen such as yourself who tell me two different things.
Yeah.
And I have to kind of decide what I wanted, two or three different things.
Well, you know what, Jimmy? That's exactly what David Muslin said to you. It's just your own risk preference, and it's how
Yeah.
far you want to push it. And if you're ready to take the risk, do it. If you're not
Right.
ready to take the risk, at least go another 3 months. You got through the 18 months, and then you're not going to beat up on yourself if it does come back and say, oh, if only I'd have done the 18 months.
If
So,
only I'd listened to Rick.
no, it's not about listening to me. You know, I mean,
I don't want to come back here. I don't want to come back here and eat crow in front of you, man.
oh man, you know we love you already. You've only been with us 3 times, and you're a star.
All right.
So
Move on and get me out of here. There's nothing else
okay,
to say about me.
I'm moving on to Tracy because we lost Mark Finn, which I'm upset about. I got to send him a note. He did say leave him till the end though. But Tracy, you had something, and I think you are the last gent up tonight.
Okay, it's been a while since I gave a update, so I just figured I'd give an update. Basically, all my numbers are really good. Platelets are up to 385. This is really good considering this is about my 4-month anniversary of really figuring out, what was going on. And then we're down to 80. So it was pretty severely anemic at that point. PSA is undetectable. Testosterone is around 10, which is exactly where my doctor said it would be. Eosinophils, they are at the very low edge of normal, which is exactly great, what I'm looking for. So basically, it looks like I'm in a dormancy state. And so now my real big focus, and I really wanted to thank Ken for comments he made about making sure you watch sugar. And also, I believe it might have been Rick or Len that was commenting on the Mediterranean diet and exercise. So that's what I'm really focusing on now. Couple months, I'm going to make a decision about getting into a clinical trial where they're going to remove the prostate. Basically, they said, I've been told that they found some positive aspects to people that are stage 4 having the prostate removed. So that's available in probably about 2 months. I did get a new primary care physician, or I'm getting one. My last visit to him was, it did not go well. It did not go well. So I'm going to be looking for new primary care. And I followed your advice as well on the long-term disability forms. I've got my letter back from Social Security as to a date when they've received it. And so that's my start date. It's not approved yet, though. So I just wanted to thank you guys because it's really been a good roadmap that you've been able to, even though I don't know everything about it yet, you guys have really helped me with a good roadmap as to what to do the first couple months. And I've had a good response to that, so thank you.
It's our pleasure. You raise one really interesting issue. I don't know if the guys want to discuss it or we can discuss it next time you're on, but if you are going to debulk your tumor, should you do it with a radical prostatectomy or should you do it with radiation? We've got people that have done both on here. I know if it was me, I would certainly do it with radiation.
Yeah, so at the next appointment, basically, we're going to discuss that, and that was either removal or using radiation. So that was part of the discussion I'll have next time with my oncologist.
Well, I don't. Let's bring it up next time. But on this call, for example, Ken has done it with radiation. Carl Foreman has done it with surgery. So we, closer to the time, we can talk to you. But I would say that it is probably standard practice now. I don't want to say standard practice, but it's very common amongst a lot of good GU medoncs to recommend that if you're de novo metastatic, you treat the gland. Question is how you treat it, how extensively you treat it.
Yep.
And don't forget proton pencil beam, because that really it ablated everything, the prostate and the prostate bed. And I know it's in the future. You're going to end up doing a lot of proton beam therapy, but it's newer. Not everyone has it yet. But I'm a big proponent of pencil beam proton therapy, to use that to ablate your prostate. And I know how you feel, Rick, but I just have to say that. I got to promote it.
Well, I mean, look, there's nothing wrong with SBRT, whether it's pencil beam proton or whether it's photon. I think the bigger issue is, are you going to do surgery or are you going to do radiation? Then the type of radiation we can talk about again.
Yep.
Yeah, that's I think where, I don't want to get into a discussion of is photon better than proton or proton better than photon.
Odds are I won't have a choice, right? They're going to have one or the other anyway. So.
Well, I mean, you can pick the place you do it.
Yeah, that's true.
Depending on what you want.
True. I have to do some research yet.
I ended up traveling to California to UCLA because after review, I felt the ViewRay SBRT with MRI guidance was the safest and the latest state of the art. So I think that's really good. You have to find a radiation oncologist that you trust, and don't just talk to one person. Get opinions from different centers of excellence and different people. I don't know that Atlanta is the center for the best care for prostate cancer. So with telemedicine now, we can talk to a lot of people in a lot of different places, and it's worth it.
Okay. Thank you.
Okay. All right, guys. Let's just see. It's 10 after 8. I think we're done. Have I missed anybody? Is there anyone who wanted to say something that didn't have the chance? Okay. Well, it was a great meeting, an interesting meeting. Again, since this is the last meeting of the year, don't forget the pointer that I put in the reminder that we've got Epstein talking to us next on the 30th, whenever that is, next week, a week on Wednesday, I think. He's worth listening to. He is the guru of pathology as far as prostate cancer is concerned.
I thought it was Epstein.
And it's Epstein, not Epstein. That's what we learned from Elliot. Secondly, again, you know what, we don't pitch, but please, the only time we pitch is the end of the year, and I know we've had a good response, and I know some of you have given, but if you haven't, just think about it. It doesn't matter how little or how much. Much is better than little. But that said, we really would appreciate it if you can come up with something. And I want to wish everybody a really safe and happy holiday, and more than that, a very, very safe, a very, very healthy 2021 for everybody. And that's it. I'm done.
Happy holidays.
Anybody else have anything?
Happy
or can we switch
holidays.
off? We're switching off. Good night, everybody.
See you next year.
Good night, everybody.
All right.
Bye.
Thanks.